35 years ago, a movie Karate Kid came out. It's been remade since. But in the original one, here you see the young student practicing karate with his master. They were preparing for a tournament, and the student said, "I just don't know if I know enough karate." The master said, "Don't worry about how much you know. Trust the quality of what you know." I think perhaps we as a faculty spend too much time making sure that you know every single test that has been identified in the history of humanity. I think it might be more productive if instead of worrying so much about the quantity of tests, that you instead worried about the quality of your clinical decision making. And so we're going to talk more about that in this presentation. So to start out, when you meet a patient, you do your interview and you develop a hypothesis. Say that your patient's diagnosis is knee pain. But they are a runner, and that knee pain came on gradually. It's felt after a few miles. They can do most ADLs without problems. You wouldn't think that it would probably be a ACL injury, so you probably would not actually need to test for ACL rupture. So based upon your interview, you develop a clinical hypothesis, and then you look at multi-segment tests. And we're going to talk a lot about these multi-segment tests today. And do you see motion patterns that support or refute your hypothesis? For example, with your patient with patellofemoral pain, you might see a Trendelenburg sign and a dynamic knee valgus with single leg squat. For a few reasons, those two motion patterns explain a lot about patellofemoral pain. However, those two motion patterns can be coming from a few things. Quite a few things, in fact. So after we've determined that probably the patient's symptom of patellofemoral pain is linked to this movement pattern of dynamic valgus of the knee, we need to do specific structural and strength testing to try to find out what structure or what muscle group is responsible for this maladaptive movement pattern. Remember that part of this testing the hypothesis is asking the question of, does what you see explain the symptoms? If you see a patient with very pronated feet and their problem is plantar fasciitis or tibialis posterior tendon dysfunction, then indeed the foot pronation goes a long way toward explaining their problem. However, if the patient's problem is medial compartment knee arthritis, then that foot pronation really doesn't explain their problem. Do remember that unlikely diagnoses sometimes are true. So if you do all the patellofemoral tests and motion patterns and you find nothing that explains their pain, it actually is possible that the patient might have ACL injury, especially with an older patient. So if you go through that initial examination, testing the hypothesis that their problem is patellofemoral and don't find anything to support your hypothesis, then it is appropriate that you go back and test some other hypotheses. The first multi-segment test that you're going to want to do with these lower body patients is the double leg squat. With the double leg squat, you can assess the frontotransverse dynamic alignment of the femur, because remember, the hip joint is a three-dimensional joint. It's a ball socket joint, and its movement frequently is a combination of adduction and internal rotation, or abduction and external rotation. The frontal plane alignment of the knee, remember a lot of times that what looks in the frontal plane as valgus and is indeed described a dynamic valgus is actually a combination of valgus of the knee and external rotation of the tibia or internal rotation of the femur. We're going to talk a little bit about this later in this lecture. Assess the foot progression angle, to what extent are the feet pointing outward, and the dynamic alignment of the subtalar joints, which is actually, and we're going to talk more about this as well, way easier to maintain in a neutral in double leg than it is in single leg. If you look at the two patients on the slide, the woman in the two pictures on the left, even though she has external tibial rotation, she's doing a pretty nice job of maintaining her knees and femurs in a neutral alignment. Opposed to the woman in the right, you can see that her feet are spread out, but those knees are pointing toward each other. Definitely an example of what we call a dynamic valgus. Now, if there are no movement abnormalities, which explains the symptoms that you see in double leg squat, then progress to the single leg squat. If, on the other hand, you see something like the woman on the right in the double leg squat, then you've got stuff that you ought to work on. And this is how you measure the malleolar torsion. It's a measurement called the thigh-foot axis, or the thigh-foot angle. So the axis of the goniometer is right between the malleoli. One arm is bisecting the thigh, and the other arm is bisecting the foot, going through the second metatarsal. This patient here, this individual here, has a very small thigh-foot angle of about 10 degrees. When you assess a patient's squat, don't forget to assess it in the sagittal plane, because being able to maintain that anterior pelvic tilt, like you see with the fellow in the picture, means that the person is able to distribute the external the external flexion torque through both the hips and the knees, rather than concentrating it all in the knees, such as you see here. And also, by deploying that anterior pelvic tilt and stretching out the glute max in the sagittal plane, they improve the length-tension relationship and are better able to control the femur in the frontal and transverse plane, which can help prevent the issues that we've been talking about a little earlier in this presentation. As we go through these next couple of slides, I'll also describe how they're organized. So with this individual of whom you see the photo on the right, we see frontal plane dropping of the contralateral pelvis, also known as the Trendelenburg sign. In the black, you see the phenomenon that we are observing. In the green font, we're seeing possible causes. So this is likely caused by poor control or weakness of the hip abductors, in this case on the right side. And in the red font, you see potential consequences of the movement abnormality which we're observing. So that could cause lumbosacral compression on the ipsilateral side or on the right side, or IT band related problems such as greater trochanteric bursa pain or IT problems around the knee like friction syndrome or patellofemoral problems. You see the abduction of the femur, which is likely due to poor control of the hip abductors. And remember that the hip abductors are big fan-shaped muscles, including the gluteus maximus, and they control the angle of the femur on the acetabulum in a wide array of joint angles. Also, the hip external rotators are important as well. But remember, those big abductors, especially the glute max, have not only more muscle mass, but a better moment arm of muscular control. So in a way that we'll describe in a little bit, really specifically, that adduction of the femur and internal rotation of the femur can be associated with patellofemoral problems, or because of the valgus of the knee that you see, increased risk of ACL injury. Internal rotation of the femur with external rotation of the tibia, again due to poor control of hip external rotators and abductors. There's a lot of overlap between those muscle groups, which can cause a higher Q angle, as you could probably perceive by looking at the photo. Now, if you were to see dynamic hindfoot valgus with such a patient, harder to see with shoes on, but you can imagine that might be due to structural hindfoot valgus, structural forefoot varus, or insufficient talocrural dorsiflexion. We talked about this, I believe, before, but if the talocrural joint does not dorsiflex again, then the midfoot needs to dorsiflex. In order for that to happen, the talocrural, or rather the subtalar joint, needs to be in pronation. So that can cause the movement abnormality, as seen in red font, of internal rotation of the whole lower extremity, which can contribute to a greater Q angle and contribute to the problems that we've described in the last slide, as well as problems related to control of the medial ankle and lower leg, such as overuse problems of the tibialis posterior, overloading of the connective tissue of the midfoot. The lateral foot progression we described before, and what happens with that again is that the internal plantar flexion moment is causing not just an external knee extension moment, but also an external knee adduction or valgus moment. And that can contribute to ACL problems, or also because of the valgus of the knee contribute to risk of ACL injury. Sometimes, and you can't see it in this case, but you may also see an ipsilateral trunk lean during this test of unilateral squat. And that can be due to poor control of the hip abductors or poor control of the ipsilateral trunk. And we're going to show you ways to test that over the last few slides, which can contribute to lumbosacral compression on the ipsilateral. Now we're going to discuss in detail some of the consequences that you could see from the movement abnormality of high degree of internal rotation of the femur relative to the tibia. So what you see here, actually, I'll show you with my pointer. What you see here is first of all, the patient at rest, and we can see already at rest that her patellofemoral joint looks pretty unstable. We see a great degree of lateral tilt of the patella and quite a bit of lateral glide. However, look at what happens on the bottom photograph here. So these are taking place within an MRI. The first MRI image that you see, the patient is non-weight-bearing with the knee extended. The second, she is weight-bearing with the knee flexed a little bit. So as the knee flexes, the femur goes into a great deal of internal rotation, and you can see that, in fact, the rotation of the femur on the bottom image relative to the top image. And we see the patella glide almost completely out of the intercondylar groove. Now, the intercondylar groove is very shallow in this patient, which is probably contributing to her problem. But what we're interested in thinking about here is the movement abnormality of internal rotation of the femur, which is really common, again, with poor, especially with poor hip control. So the potential consequences of that problem to the patellofemoral joint include high pressure between the patella and the lateral femoral condyle, and tension on the medial patellofemoral restraints like the medial epicondyle and the medial patellofemoral ligament. Now, over the past couple of years, we've talked about how you almost never have exactly one muscle or exactly one structure that is responsible for a biomechanical goal. And so it is such with resisting the external hip abduction moment during the stance phase of walking, running, climbing stairs, etc. That is a combination. That goal is accomplished by a combination of muscles and muscular control and the IT band. So they're working together. What happens sometimes, if the muscles are not carrying their load, very literally, is that the IT band can compensate and become tight. So what you see on this slide is the overside, which I think you're familiar with. The panel A is the preparation. Panel B is letting the thigh adduct. On the first panel, the thigh does adduct, so that would be a negative sign. On the second panel, the thigh does not adduct. Now, I have never actually seen a thigh stay in that much abduction, but it gets the idea across. If you see the ipsilateral trunkling during the single leg squat test, that could be due to poor trunk control or poor hip control. To test for poor trunk control, do the side plank test on both sides and compare the amount of time that the patient is able to maintain the side plank test, which really tests all the trunk muscles on the downward side. Compare the time on the involved side versus the non-involved side. In order to test hip control, the hip hike test is really a great option. The reason that it's such a good option is that you're testing the hip muscles in the way that they actually have to work, in the closed kinetic chain, moving the pelvis over it, or at least stabilizing the pelvis over it. Even though you may have equality in manual muscle test of the strength that the hip abductors are able to maintain, you may see that there's a deficit because of a deficit in endurance or closed chain control. Of course, if you suspected a deficit, you'd want to do manual muscle test as well. The tests that we thought about in this lecture are not the only tests that you would want to do in a sports physical therapy evaluation. You'd also want to do more basic and familiar things, such as manual muscle test of the hip abductors, of the quadriceps, assessing the alignment of the hind foot and the forefoot, goniometry of the dorsiflexion, and special tests that are indicated by the signs and symptoms. However, what I've tried to show you with this lecture are some things that I think are kind of unique. In doing some really simple movement testing, although not exclusively that movement testing, and being able to draw some really important conclusions about your patient's clinical problem from them.